In this case, I'm going to discuss other than glaucoma defect. So there are few. I just going to 3 or 4 videos, just 3 or 4 slides, just simple. Okay, let me explain. This is the normal parameters. Arcuate defect you can see in glaucoma, or you can see in ischemic, something like AION or papilledema in case of late stage. Altitudinal defect is optic neuropathy, so secondary to ischemia or glaucoma, but it's rare in glaucoma altitudinal defect. But vascular, it's definitely vascular defect. There is enlargement of blind spot. It's typical case of papilledema. It's very typical case in case of papilledema, enlargement of blind spot. Central scotoma is definitely with the macular pathology, or optic neuropathy. Central scotoma is there. Okay, sometimes it's called centricecal. And centricecal, in this case, see, center and the blind spot is joined. Okay, centricecal is common with the optic neuropathy, so it's very common, centricecal. Bitemporal hemianopia is a typical case. Whenever you see bitemporal hemianopia, what do you think? So first thing you think, papilledema, isn't it? So sorry, pituitary adenoma. I'm sorry. So there is something compression in the pituitary adenoma or pseudochiasmal defect. Sometimes pseudochiasmal defect it may cause, for a minute respect, but tilted disc by temporal retina cases, toxicity. Sectoral RP, I don't know that's very common or not, but say junctional scotoma. You see this junctional scotoma? Okay, junctional scotoma is prechiasmal or optic nerve lesion in compression. Any, as you know, I think you remember your visual pathway, and then you'll come to know where the junctional scotoma, isn't it? So homonymous, it means in the same side. Heteronymous, it means in a different side. So in this slide, all are homonymous, isn't it? Same side, like this, same side, right 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 side of the visual field. Yes. Incongruous, yes, not exactly, relatively, incongruous, relatively anterior in lesion. So it might be post-chiasmal or optic tract defect, lateral genicular nucleus incongruous, or optic radiation defect. Homonymous but congruous, exactly same, isn't it? Optic radiation defect, superior loss, or optic radiation, parietal temporal loss. And homonymous complete, half is complete, isn't it? So occipital, high congruity, and preserved optokinetic nystagmus and temporal corresponding, and crescent to macular sparing. I don't know about it. Homonymous, it's temporal crescent sparing. So this part is even till clear, isn't it? So the macula is sparing means macula is, the central part is good. So it's sometimes occipital. So it's basically straight, calcarean cortex or posterior cerebral artery occlusion disease. Something, and in that particular case, the central fixation is sparing. There is no visual field defect. Homonymous macular defect, same side and macular defect only. So occipital tip, homonymous macular defect is only occipital tip head injury. Okay, constriction means the central part is good, the peripheral part is constricted. So it's common in retinitis pigmentosa, isn't it? Or too much of extended PRP is given. So optic disc advanced glaucoma, it's also there, but yes, in advanced case that's too much. A non-organic field defect means generalized constriction regardless of target. And spiraling, yes, definitely is a case of hysteria. So these are the few visual field defect that I want to show you. That's what. So basically, this is a reference for previous video and this video too. And I have taken the reference of this visual field testing glaucoma, particularly David C. Bordway, and I have taken a lot of things from the Oxford Handbook, and definitely from these 3 books too. Okay, so Pistan, cheers.